You can see me? My,
Yes,
but share button of the slide is not there.
Yes, yes. Share button will come once your chance will come.
Okay, fine, fantastic. Yeah.
Once again.
Good evening, everyone. We welcome you all to Ortho TV Online. And today we have ASSI Master Series webinars on complex craniovertebral anomalies. And we hand over to our host, Dr. Gautam Zaveri.
Good afternoon, ladies and gentlemen who are watching us on the Zoom platform and those of you who are watching us on the Ortho TV platform. Welcome to the ASSI Master Series webinars directed towards spine surgeons, neurosurgeons, and surgeons who are mainly interested in spinal surgery. The final bastion to conquer for a spinal surgeon is the craniovertebral junction, which is a very complex region with complex vertebral and ligamentous anatomy, a lot of vasculature in that area, and extremely vital neural structures like the brainstem and the cervicomedullary junction. To discuss this, we have a fantastic panel, probably one of the most eminent panels of spinal surgeons or surgeons specializing in complex craniovertebral anomalies. The moderation of the session and case presentation will be done by Dr. Satish, a neurosurgeon from the Sakura World Hospital in Bangalore. Along with him, the panelists are eminent people: Professor Sanjay Bihari, the head of Department of Neurosurgery at SGPGI in Lucknow; Professor V.K. Jain from the Max Healthcare in New Delhi. We have Professor S.K. Srivastava from the head of Department of KEM Hospital in Mumbai; Professor Sarat Chandra, whose work on the craniovertebral junction is very well recognized. He is from the All India Institute in New Delhi. We've got Dr. Praveen Salunke, who is from the Postgraduate Institute in Chandigarh; Dr. Mir Bapat, a leading spinal surgeon from Mumbai Nanavati Hospital; and Dr. Sandeep Sonawne, who is an associate professor in orthopedics, who has done a lot of work on the craniovertebral junction, and he's also from the KEM Hospital in Mumbai. The program will be such that it will be an interactive case discussion session, and at relevant points, specific videos with technical tips will be given to you by our panelists. The question will be a freewheeling discussion. I am available to all of you on Ortho TV, and I'll also on WhatsApp. My WhatsApp number is 9820504351. I repeat, it is 9820504351. If you have any questions on the subject, please feel free to ask me the questions on the WhatsApp, and I will put it through to the panelists so that your questions are answered. So without much ado, let me stop sharing my screen and hand over the screen to Dr. Satish to take over proceedings from here on.
Thank you, Gautam. Can you? Thank you,
Yes,
Gautam.
We can see your screen and we can hear you, Satish, so please proceed.
Yeah. So today's talk is completely on the congenital CV junction anomalies. The last presentation of ours was related to odontoid fractures and related to that, and today we are just checking on to congenital CV junction anomaly. And all of you know, whenever a patient presents like this, this is one of the examples which I'm giving. An 18-year-old male. Classically, most of these patients come with a spastic gait, grip weakness, and most important for them is a physical examination. So in this patient, you can clearly make out the three things which are evident in is just looking at the patient. That is a low hairline, low set ears, short neck, and facial dysmorphism. So whenever patients with these morphological picture which they come along with the quadriparesis, it is evident that the patient has a problem in CV junction without any, much of the examination of the radiological examination. a good doctor can make out that this patient might be having a problem at the CV junction level. So this is the patient's picture. You can clearly make out in this patient. This patient has there is a significant CV junction anomaly. There is a occipitalization of the atlas. Is the slides moving?
No.
Hello?
No, it is not moving.
Take your mouse on the slide and then click once, and then it will start moving.
Yeah. So you can clearly make out that there is a significant anomaly in this patient. There is a C1 hyperplasia. There is atlantaxial dislocation. There is a clipple field anomaly. So this is yet another patient where in a simple X-ray in most of these patients will show significant pathology. In this patient, you can clearly make out there is a significant clipple field anomaly of the almost whole of the cervical spine. The C2-3 is the maximum one. And in addition, patient has a atlantaxial dislocation located completely in this region of this patient. And another patient where you can clearly make it, there is a hyperplasia of the C1 lateral mass. At the same time, there is a os odontoidum, and the patient is having problem related to the atlantaxial dislocation. This is yet another patient with a classical X-ray finding of a bifid spine. Literally one half of the C1 arch is different from another half of this patient, and posteriorly it is not fused, anteriorly it is not fused. You can clearly make out in this patient how the development of CVJ happens and C1 arch forms, and how the lateral masses and the anterior arch and posterior arch separately ossify from different parts of the ossification center. So this is yet another patient where once again there is a basilar invagination, clearly basilar invagination, occipitalization of the atlas, and there is a clival abnormality. So all these things are very well known in these patients. So in this webinar, what we are looking, our learning objective for this webinar is what are the symptomatic, which are the symptomatic congenital CV junction abnormalities, what is the embryology of it, and is there a strategy for surgical approaches of CVJ anomalies, and tips for safe surgery and complication. To discuss all these things, we have a wonderful faculty along with me, and I'll be projecting the cases and they will be answering which way to take it. The first few slides, I'll be talking about the basics of the CVJ, and then we move on to the cases directly. So if you look at the radiology of the CVJ, these are the important points any spine surgeon or a neurosurgeon or a orthopedic surgeon should know about it. So clearly it is because most of the lines which we mark in this region of the CV junction depends on, these are the points, 7 points, which are very, very important to identify things. So this is, we can clearly make out in this region, the atlantaxial area, and all these points are required to measure some of the radiometric analysis. So what involves the CVJ is the lower clivus, the foramen magnum, C1 and C2 region. So you look at the embryological way, the clivus, this is the clivus, which is formed, which has a fourth segment, which comes from what is called as hypoglossal sclerotome. The upper three forms the 2/3 of the clivus. The lower segment of the sclerotome forms part of the C1 lateral masses and arch, which I will tell you how it forms. So literally speaking, if you go to any embryological book, they say that there are 3 segments which are very, very important in this region. One is the pro-atlas, otherwise the hypoglossal part of the sclerotome, the C1 sclerotome, and C2 sclerotome. And if you look at this, the color picture, you can clearly depict the pro-atlas, otherwise the hypoglossal sclerotome, give rise to as the occipital condyle, then the tip of the odontoid, the part of the lateral mass of the C1 arch, and upper part of the C1 arch, posterior arch. Whereas the C1 sclerotome, it gives rise to most of the anterior arch of the atlas, the part of the dens in the lower part where it fuses with the C2, and the lateral mass of the C2 and the lateral mass of the rest of the C2 area is given by the C2 sclerotome. The lower part of the body of the C2, the laminae and the lateral masses of C2 is purely by the C2 sclerotome. So if you look at this picture, it clearly says that by 3 years, we will have a reasonable development of the axis rather than the atlas. And the joining of the odontoid with the C2 body happens by the age of 12 years. Whereas the tip of the odontoid fuses with the rest of the body by 4 years. And the posterior arch of the atlas also formed at 4 years of age. So this embryology is, forms the complete junction of the CV junction. You can clearly make out by 12 years of age. A matured CV junction is seen by 12 years. And if you do any surgery beyond 12 years, it is almost like an adult. But before the 12 years, there are a lot of cartilaginous elements, especially in the posterior C1 arch, you can clearly make out, as well as in the lateral, the mass of the C1 sometimes will be significantly cartilaginous. And this anatomy is supported directly by the multiple ligaments in this region. Because of the high mobility, luckily the nature has given good amount of the ligaments, which holds it anteriorly as well as posteriorly in this region. And if you see the coronal section of any CVJ, you can clearly make out in this, the most important is the cruciate, part of the ligament. The mid part of the cruciate is nothing but the transverse ligament. Then we have the apical ligament, and we have alar ligament, which holds it. And if you see from axial sections, laterally, the alar ligament holds the odontoid. The posteriorly, the thick, the transverse ligament holds it. It's almost about 2.5 centimeter, located at the anterior part of the lateral mass of the atlas. From one lateral mass to another lateral mass, it goes, and the odontoid will sit in that position between the transverse processes and the anterior arch of the atlas, and it gives the good mobility to the patients. And these ligaments are the one, in addition to the bony anomaly, there will be laxity of these ligaments as well as the maldevelopment of these ligaments, which produces clinical symptom in these congenital atlantoaxial dislocation patients. So what is more important is the mobility which we have. So mobility is significant in this region. If you look at this picture of the Hercules, what he has kept is the globe, the whole earth globe. He has held the hand on the side of the globe in the obliquity. Same way, the round head along with its brain is kept on C1, C2 in an obliquity of 35 degrees. And if it is straight, it would have fallen forward. But when you keep it, when it is kept at 34 degrees, it is held, the head is held very well at C1, C2 level. And in this anatomy, when you have the cross section of the anatomy, what goes through this area is the lower part of the medulla and the upper part of the spinal cord junction. The right hand picture clearly shows there is a decussation of the corticospinal tract in this region, as well as corticospinal tract. And there is at the upper part, if there is a basilar imagination, it can involve even the fibers of the respiratory system as well as the cardiovascular system. That's why this anatomy is very important. And many of these surgeries in these patients, whenever we do, there is a hemodynamic changes happens in these patients. There will be bradycardia and everything, all related to the cord compression happening at foramen magnum and C1 junction. And hence, knowing the surgical anatomy, mobilizing the joints is the key without compressing on the soft tissue structures. So other important element is whenever there is a bony element, there is a ligament element, and there is a soft tissue element, it needs a good blood supply. Every animal, from primitive animal to the highest developed human being, there are two vertebral arteries which are kept on either side. You can see the sections here, anterior sections, next to the odontoid it passes, the vertebral artery. And posteriorly, this is where many of the surgery are taken place. You can clearly make out it sits about 2 centimeters away from the midpoint of the C1 posterior arch, and the C1 arch becomes superior inferiorly flattened. On this, the vertebral artery sits, and see from C2, it loops around about 1.5 centimeter, 5 millimeter to 6 millimeter away from the pars of the C2, and then re-enters into the foramen of the C1, drags over the C1 arch, and there is a dural ring at the foramen magnum through which it enters into the anterior part of the medulla. And this anatomy is the key to understand the all surgical procedure in this region. And any anomaly which happens in this region, either it stretches the vertebral artery, or because it is congenital anomaly, all these arteries are such in such way that unless proved otherwise, you had to think every congenital CV junction anomaly will have abnormal arterial anatomy, and it's better to do CT angio in the beginning of your surgical process. And as you progress, sometimes you can think that it's abnormal, and preoperatively you can use the Doppler technique and do it. This is what is the distance which I was telling, how it goes on the C1 lateral arch. So because it's a highly mobile segment, and if you see fetal position of the child, where the head is bent down and the arms and the legs come closer to the chin in a uterus, many of the abnormality can happen in this CV junction. In fact, recently I had a child whose mother, during the routine third trimester ultrasound, we could clearly make out the presence of the atlantic dislocation in such patients. And it has been told in the literature, this abnormality is seen as early in the fetal medicine way by within first 12 to 14 weeks of pregnancy. So there are innumerable anomalies happens. It could be bony abnormality as well as the soft tissue abnormalities. Many of these things will happen in combination. I will not go into each one of them. Many of the soft tissue anomaly is mainly the two variety. One is Arnold-Chiari malformation, otherwise Chiari malformation, type 1 or type 2. And the second one is syringomyelia and rarely a syringobulbia. So I will show the combination of these things, but none of them, whether by alone as a solitary one, will have complications, clinical implication, we'll look into as we go into the cases. So this anomaly not only happens purely congenital way, it can happen development or syndromic way. This is yet another patient which I operated long back, nearly about 20 years ago, with Atlantic axil dislocation of the Down syndrome patient, and many more like Marcus disease and patients with achondroplasia can also come with CV junction abnormalities. Anterior arch atlas is one of the commonest abnormality you see in this patient. As you see here, it can just a split posterior arch to completely non-fused arch, you can see, or unilateral non-fusion can happen in these patients. The surgical implication is mainly when you are using the wiring technique or in the pediatric age group. This is one of the anchors which it is impossible to hold on to if there is no good formation of the bony formation of the C1 arch in these patients. So these are many other small insignificant ones which I'll not go through that. This is a persistent ossiculum terminal. You can see in this patient the tip one, but it has no clinical implications. But what is clinical implication is, when do these patients come with a problem? They come with the two major problems. One is either the Atlantic axil dislocation or with a basilar imagination. This is the main topic of this webinar. So before going through the cases, the few lines which everyone should know how to define between the Atlantic axil dislocation versus basilar imagination. As I mentioned, there are a lot of lines which have come, whether one is a Chamberlain's line, where we say the dens has to be below that. And we always mention the Wankenheim's Clivo canal line, which we always say the intersection from the Clivus and the dens, the odontoid should not cross beyond that level. And Clivo canal line, it should be around 150 to 180 degree. And if it's less than 150 degree, we say there's a ventral compression. And similarly, if there is a platypesia, if there is a more than 140 degrees, we call it platypesia. And in an AP X-ray, all these things are done by X-ray, remember. So X-ray is the first common investigation everybody should do. Fishgold line clearly mentions that how these angles can change in these patients, and basilar immunization will be directed towards these things. For example, Atlanta occipital joint is at 124 to 127 degrees, and if it is obtuse, we call occipital condylar hyperplasia. So whenever there is occipital condylar hyperplasia, you have to imagine there is a basilar imagination. So it will not produce the Atlanta axil dislocation. So whereas in atlantoaxial instability, we mainly look at atlantodental space and the posterior atlantodental space. So if there is atlantodental space of less than 3 mm should be there in adults and less than 5 mm in children. If it is the posterior space should be minimum available for normal cord functioning should be more than 15 millimeter. So anything more than 7 millimeter of atlantodental space, we call there is a atlantoaxial instability in these patients. So clinical classification, we have classified mainly into symptomatic ones, which are most of them produces basilar imagination, and whereas ossified os odontoidum and Klippel-Fill anomaly present mainly like atlantoaxial instability. Asymptomatic are many. Anomalies are usually symptomatic when there is a atlantoaxial instability or basilar imagination, as I mentioned before. Combination is the rule, rarely isolated when asymptomatic when isolated. So clinical features, as I mentioned, is related to the soft tissue component compression. I'll not go into the details of it. So age of presentation, it varies. It can present as early as immediately after the birth to some of the patients we have seen. Usually they'll present at 20, 25 years, but many of them, when they develop this cervical spondylosis in addition to CV junction, can present even at the 70 to 75 years. So age is variable. So investigation wise, X-ray is mandatory in all these patients. In X-ray, you had to do AP and open mouth, and lateral when you do neutral flexion and extension one. And MRI is the next investigation which should be taken into consideration to see amount of the cord compression, followed by a 2D or 3D CT to see your bony anatomy, which is very essential for your surgical planning. So especially seeing the amount of the basilar imagination which has happened, the amount of the space available between the cord and the odontoid, and amount of the lateral joints, and the height of the lateral masses which are available to you, and the angulation with which it has displayed is important. That's why CT makes enormous importance to you. And especially when you do, along with it, present day, we do a 3D modification models, which will give an idea pre-operatively how you can approach these things in a different direction. So let us go into symptomatic Cvj. Here starts my case presentation. Scenario one, here is a 16-year-old male patient. You can clearly make out. I will ask now Praveen, could you please tell me what exactly you find in this X-ray and anything which it strikes you?
Yeah, you can clearly see that there is atlantoaxial dislocation. Os is possibly not developed, or it is there is a os odontoidium, which may be better picked up on a CT scan, and there is movement on flexion and extension. So it reduces on extension, maybe slightly more than what is required.
Correct, correct. And you're perfectly correct. In this patient, you can clearly make out there is an os odontoidium here, and the lateral joints are very well aligned. There is there is a high riding vertebral artery in this on the other side, and the MRI shows classical compression at this region. What is the procedure you would love to do, Praveen, in this patient?
I would like to fix the C1, C2 joints.
And what is the normal method you follow in your institution?
What we do is we open up the joints, drill open the joints, denude the cartilage. If required, a part of the bone can be drilled, but in this particular case, it is not required. It can be just packed with bone pieces, and then we put in a C1 lateral mass and C2 pedicle screws, and then fix it as close to the joint as possible in the reduced position.
Excellent. Mihir, do you have anything to say? Mihir Bapat?
Mihir, you'll unmute.
Hello, yeah. So I think in this case, I agree with Praveen. It's a reducible atlantoaxial dislocation. In fact, the worrisome part here is that it's hyper-reducible. That means you can almost see the C1 going into retrolisthesis on the C2. So one has to, it doesn't matter too much, but one has to be careful while fixing it. You do not fix it in over-reduction as well. So you get the anatomy correct and you fix it with a C1, C2 fixation.
Excellent, excellent. So this is, this topic on os odontoidium, and it's a reducible atlantoaxial dislocation. And what we did is in this patient is C1, C2 cable fixation, as well as the unilateral transarticular screw fixation, and patient did very well. So any of the methods can be used for these patients. The second patient is what I was showing you all this time. I will ask, Professor Srivatsava, what are the X-rays? Can you tell our audience, how to read this X-ray of these patients?
So this patient has actually the AAD, which is very clear by seeing the distance between dens and the anterior arch. It is getting reduced in hyperextension. You can see the alignment comes and it falls into place. Now, there appears to be congenital fusion of the posterior element. And here we can see the C2 and part of the C3 looks fused there. So since it is reducible, so there should not be much problem, and there doesn't appear to be any element of basilar invagination. Now, I would like to actually know the clinical presentation of this patient, and then we can decide.
Clinical patient, this every patient which I'm presenting here are all the patients who had a quadriparesis and gait difficulty with posterior column involvement. And without any sphincter involvement. All the cases which I'm going to present, everybody had a quadriparesis of variable quadriparesis from grade 2 down, not to grade 1.
So here one would like to see the MRI and CT of this patient, and one can decide the plan. So
here is MRI, which shows there is a cord thinning. Yes, sir. Go ahead.
There is a compression definitely. So this can be reduced. It is a straightforward case of C1, C2 fixation in aligned position. So I think that would solve the purpose. Now, usually I pay attention on the clivus canal angle. That is the most important radiological criteria when you do any surgery of this region. Once you try to achieve this a good clivus canal angle, most of the time this compression goes away. So the aim should be to try to be have a normal clivus canal angle. So once you align this column, usually you get a nearly normal clivus canal angle. Since this is reducible nicely, so I think we should be able to achieve that.
Okay.
Now in CT, the problem is there of the posterior arch of C1, where posterior arch of C1 appears that as if it is not there on one side, partly on one side. But in plain X-ray, if you see, there appears to be an element which is looking bifid there. So in that case, it should not matter much because we are going to have a fixation in the lateral mass, both the side in C1. So that should not matter much. So C1 lateral mass fixation and C2 pedicular fixation, and that should suffice.
And if you see at one particular level, when a point, the C1 is the os time is toppling over the C2, and sometime realigning the joint will give the better. As you said, the clivocanal line becomes normal when you realign the joint in these patients. You have a very good point to take. That clivocanal angle has to be very good. Praveen, would you like to add anything, your procedure or anything else?
Yeah, I would like to have a CT angiogram, as you had
CT angiogram. This patient has a CT angiogram is normal. There is no significant abnormality.
Then I would just do the way Dr. Srivastava
said. Okay. So in this patient, so there is, in fact, this patient if you see the hyperway, the os odontoideum was coming in front of the C2. So, and it was not reducing because there is, in fact, it was looking that because the posterior arch was looking bifid, it was looking reducible, but os odontoideum coming and hitching, and C2 was hyper, going backwards in the hyperextension. So in this patient, to align the joint, we went C1, C2, open the joint, put the spacer on one side, and the another side, we put the bone graft and aligned it and formed C1, C2 joint space, is distracted. So this is yet another patient. Sandeep, you want to comment on this patient?
Yeah, so in this particular case, I can see that there's, although the X-ray would have been a little better, but I can see that there is definite hyperextension of the odontoid process. So I assume that there is atlantoaxial dislocation because I cannot see the C1 arch very clearly. But definitely there is a dislocation of the C1, C2. The rest of the parameters I can't comment regarding the occiput and the basal angle. Yeah, now this is better because you can see that there is superior translation of the odontoid tip. There is a reduction in the cervicomedullary angle as well as the clivus angle. So there is AAD as well as a BI in this particular case.
Okay. So if you see here, the clivus becomes almost horizontal, like a platybasia in a neutral position, and the patient when extends, it becomes vertical. And there is a occipitalization of the atlas posteriorly, and between the occipitalization and this, it is getting completely compressed. So when you hyperextend, you can clearly make out the clivus is standing over, and there is a pseudo joint between the tip of the odontoid as well as the clivus in these patients. So the lateral joints are very aligned, and what is this called as bone string effect is very common, especially in the hyperlordotic way in these patients. It's almost like a fixed AD with the toppling of the C1 lateral mass. And for this patient also, we went ahead and C1, C2 fixation, and patient did significantly clinically better in these patients. So these are the three varieties of patients where we had, different atlantoaxial dislocation patients. This is yet another patient. Can somebody comment on this, Professor Srivastava?
Yeah. So again, he is here. If you see, it is in grossly dislocated position. Almost dense is going till the posterior arch of the C1. So, and it is anomalous, and there is a significant kyphosis in that area. The CT would give a better picture if I could see the CT and MRI of this patient.
Yeah. And this is the CT of the patient.
Yeah. So here again, this is a gross congenital anomaly, and here I think reduction will be really difficult because there is a bony mass anteriorly. So in such situation, I think the anterior thing is important. If suppose you find that it is not coming in, in the alignment, I think these are the cases where one can go anteriorly and try to bury it out and bring it to, near good clivus canal in alignment. The other ways is that if you distract the joint, it might slip more anteriorly. I'm talking about the dens, and one might get a little more space posteriorly. But seeing the bar anteriorly, I have a doubt about falling that into position.
Okay. Dr. Jain? Dr. Jain is there?
Professor Jain?
Professor Jain? Oh, he's not connected. Okay.
Yeah, he's here. He
can you ask him to unmute?
He's not muted.
Professor Jain, can you hear me?
He is muted, I think. We cannot hear him. Okay. Sir, you have to unmute yourself.
You have to unmute yourself, Professor Jain. Okay, let's move on. Ask somebody else, then we can get to.
Yeah, Praveen, can you comment anything how you will approach this?
Yeah, because over a period of time, I've realized that most of them are actually reducible from the posterior approach. I'm more comfortable with the posterior. Maybe somebody who's comfortable with the anterior retropharyngeal approach, they can do that way. But I would like to go posteriorly, open up the joints. We can see that there is complete spondyloptosis, and it is still possible. It is still possible to actually open up the joints, and if required, a part of it can be drilled. And once the joints are distracted, this is likely to get reduced. So after that, we can just, it's a standard C1, C2 fixation using the C1 lateral mass and the C2 pedicle screws.
So, Satish, can I make a comment?
I'm coming to you. That's what I said. I was about to come to Sharath only. So go ahead, Sharath.
Okay. So I'm happy you brought up this case because this shows the extreme end of spectrum.
Correct.
When the joints go on becoming progressively more and more vertical.
Correct.
And this was a paper which I mentioned in neurosurgery, where I showed that the direction of alignment of joints was directly proportional to the severity of basilar invagination and AED.
Correct.
So this is something which I would call as a spondyloptosis of CV junction.
Correct.
Now, I have operated some spondyloptosis. It's not difficult. But what I find worrisome over here is that there is a ventral fusion. There is a ventral bony fusion of C1 arch with the C2. Now, I have operated cases where the joints were fused. Now, releasing joints, is very easy. You can just drill off. It's quite straightforward. You can really release it. But releasing this ventral fusion, I think, is a challenge.
Absolutely.
So in this case, I'll be very much wary about going posteriorly. So what I would like to do is maybe go ventrally first, release and drill the bone, and then go posteriorly, and then reduce it posteriorly, and then fix it. Because unless this ventral fusion is drilled out, you will not be able to reduce it only posteriorly.
Yeah.
Excellent. We have two views here. We will see how it will go. Sandeep, you have any comments?
Yeah, definitely. I would definitely agree with Dr. Sarath Chandra, because you can definitely see that there is a ventral fusion. Now, in addition to that, if you see the C1, C2 joint inclination, this is almost 90 degrees. This is almost 85 to 90 degrees. And many a times it's not possible to do it all posterior. I mean, we have experienced people over here, but I find it very difficult to reduce these sort of joints. So in this case, an anterior approach, yes, definitely is indicated, where by retropharyngeal approach, you can go in between the space between the C1 arch and the C2 anterior aspect of the body and get that fragment out, the whole fragment out. And we have done it in a couple of occasions. So the issue over here is not only the C1, C2 joint. Even if you align the joint and you follow the Transverse line, you will still find that the tip of the odontoid is still causing compression over the cord. So reducing the joint only itself might not be an answer to this.
This is the case which I done 20 years ago when the lateral plates were not available, and I will come to that how we did it at that time. So this is a classical case of os-odontoideum swan neck deformity, non-reducible AD, and plan goes from anterior to posterior. So this is what we are telling you to viewers. Here the case is different in CV junction anomaly, and your overall understanding of the anatomy and radiological anatomy especially, along with the clinical aspect of the patient, is the key in these patients. So this patient, as is said, way back 20 years ago, that was the rule. What I did is I went anteriorly, took out transforal odontoid, opened the joint anteriorly in the transforal wave only, by medial, especially opening the medial joint, and put the patient on a traction for a day completely after releasing. Then posteriorly I fused. Now it is completely fused with a long iliac graft, and I have given a long liver at that time. So this is about 20 years ago procedure, but today I wouldn't have fused so long. But as Sharath said, or Praveen was telling, the joint distraction technique from posterior would have given me a shorter fusion. But 20 years ago, this was the rule. So if you look at the os-odontoideum, there are two types of os-odontoideum, orthotic and dystopic. But the orthotic usually will not create much of the problem to the patients unless there is a significant atlantoaxial dislocation. The dystopic one usually creates the atlantoaxial dislocation in these patients. So if you look at the classification, there are various classifications came from India. I think we should be proud that Indians, we have given a lot of literature to the world about the CV junction anomaly. This is since, we are working on this from Professor Wadia. He's the first person who did the CV junction where he was doing posterior decompression, and he also has a landmark paper why we should not do posterior decompression, which will create more problem to the junction, and his paper, and he classified the group 1, group 2, and group 3 way. And Professor Jain, who is here with us, also mentioned about 4 different types of dislocation in this patient. Sanjay Bihari, who's one of our panelists, who couldn't come today, also described in a different group. Ultimately, it all did into many classification, but like scoliosis and everything of the spine, the clinical treatment base will always be difficult, and each surgeon, depending on his experience, will modify his treatment protocol. So let us get into the, there is 2 ways, reducible and irreducible. So many of you already know when it is reducible, when it is irreducible. As Praveen said, and many of the surgeons now, you think the irreducible is sometimes is a misnomer, because we don't know how to reduce it, because we have to go in the same vector, how it has fallen in the opposite direction, and by just releasing the joint at the multiple, either anterior or posterior, sometimes irreducible can be done as a reducible, and the level of fusion becomes shorter in these patients, which we will go in detail as we go ahead. And everybody knows that many of these patients, whenever they come like this, and all these the panelists also agreed that everybody puts into the patients, some patients into traction. So now I'll request Dr. Srivatsa, if there is any patient with irreducible Atlantic axial dislocation or basilar invasion, you are thinking, how long you put the patient on traction? What is your end point?
Yeah, usually we see the serial X-ray. So which suppose patient comes today, we start the traction, and that would depend upon the vector in which direction it is. And usually in extension, you start seeing that it is getting reduced. And usually we wait for 2 to 3 weeks. 3 weeks is the maximum time where you find that there is a soft tissue which is now becoming little stretchable, and you are getting some effect of the traction. So I think that is my limit of 3 weeks time.
Dr. Sharath, what is the limit? When do you say it is irreducible, and when you say that traction will not be useful to you at all?
So I never use traction. So there is no point. I've given up traction. So according to me, the only irreducible situation is when there is a ventral bone fusion, like the last case you have shown.
Okay.
Not the last case you showed. So if I were to, somebody were to ask me what is an irreducible, I would say a ventral bony fusion is irreducible. Not even joint fusion. Joint fusion also easily you can drill and remove it.
Praveen, do you put the traction, and how long, and what is the maximum level you've gone through?
Basically, my idea of the traction is not for checking or reducing. It is basically that you can assess the level of difficulty. Because at times what happens is with slight distraction, you can make out with traction, you can make out that, well, this is going to be a slightly easier case, and you need to go in with that kind of mindset. And the other thing is, there is some clinical improvement which we have noticed. So we usually put the traction about a night before in the so-called irreducible. As Professor Chandra said, most of them are reducible. And even ventral compression, as he mentions, but I don't agree to that. Even ventral compression can be drilled from the posterior aspect. So nothing is actually irreducible. If it has dislocated, it will, and it is partly fused or whatever, that is something else. But otherwise, there is no dislocation which was irreducible. A person is never born with an irreducibility. It happens with time. So that is it.
So not to confuse our viewers, there are a few tips we take for the traction. The traction, usually we use the Gardner well traction, if at all. And as Dr. Praveen and Sharath said, looking at the anatomy, most of the irreducible ones, because it is not, even if it is pulled for 3 to 4 days, sometime it will not come off. So now most centers, in the big centers, 24 to 48 hours they take into consideration, and up to 14 kgs they go. And if it is not reducible, peroperatively opening the joint, distracting the joint, and peroperatively you can reduce these patients. So irreducibility has become a slight misnomer, and reducibility can be achieved pre-operatively as well as post-operatively. So pre-operatively, we use the traction to a certain extent. Peroperatively, you can use the traction, muscle relaxant, and when you open the joint and the muscle and the joint opening, it becomes sometimes, most of the time, reducible. That is the crux of these joint in these patients. So let us move into the basilar imagination. The basilar imagination.
Before you move on there, Satish, let me interrupt you. There is a question from the audience. In a couple of cases previously, we discussed occipital hypoplasia along with a C1, C2 problem.
Yeah.
And the answer from the panelists was that you should do a C1, C2 fusion with joint distraction and put in the cages.
Okay.
There was the question, if you do a C1, C2 fixation only in this case where there is occipital condylar hypoplasia, then it may be insufficient, and that in these cases actually occipit should be included in the fusion. What is
correct? We are coming to that, because I have such cases where along with the basilar invasion and the AD, I will go to that, and at that time he should be able to understand better. I'm coming to that case next. Very good question to ask. So the basilar imagination is result of the many anomalies. So it can happen, because of the occipital condylar hypoplasia, or it could be because of the Atlanto-occipital assimilation altogether, or it could be basi-occipital hypoplasia itself can create basilar imagination. So here is the case scenario. The 10-year-old child presenting with, Dr. Praveen, can you go ahead? This is the case which you will also demonstrate the surgical procedure if at all, if you think that, it will be workable with you. Can you just explain what is this case and go ahead with us?
The young child who presented with
Dr. Praveen, can you come to the mic? Your mic is low voice. Just can you speak a bit loudly?
Yeah. So, presented with spastic quadriparesis, and as we can see here, there is significant atlantic dislocation. This I would not, so-called basilar imagination. I really don't imagination. And if we again look at the joints, the C1, C2 joint, they have actually dislocated. You can see that there's on one side, and this is also dislocated on the other side. But as we can see, the occipital condyles are normal, and for the OC1 joint is normal. Dislocation only at the C1, C2 level, and so this was the MRI. And what we did, what I did was again the same technique, opened up the C1, C2 joints and fixed them with the C1 lateral mass and C2 pedicle screws.
C2 pedicle screws. Okay, this is a procedure where C1, C2 is done. Open the joint, the spacer has been put, and it has been fixed. This is yet another case. Here's a patient with a progressive neck tilt with a spastic quadriparesis. You can clearly make out in this patient, how it is tilted to the neck, and the MRI shows, a atlantaxial dislocation, a partial basilar imagination. There's a kinking of the lower medulla as well as the upper spinal cord, and the CT also shows there is a narrow part of the foramen magnum, and there is a hypoplasia and a of the C1 lateral mass on one side, which has created the tilting. And Praveen, once again, it is your case. And how do you deal with these kind of patients?
Okay, see, the most important thing here was the OC1. If you carefully look at the C1 and C2, these are the C1, C2 joint on one side, and that's the other one. You can see that it has tilted laterally. There is a complete lateral tilt and rotation onto one side. So this is what we have labeled as lateral angular dislocation. So it actually, dislocates in multiple planes. That's I would like to demonstrate the technique as well, how to reduce it. And if you carefully look at this OC1 joint, these are nearly normal. So fusing the occipital squama to the cervical spine would not be a very good idea. I would not like to do that. So instead of that, we look at the joints carefully study this joint. You can see that the C1 is way close to the C3 level on one side, and it's almost on the normal side on the other place. So we have to plan this. Though it appears to be extremely vertical, it can be drilled, and we can actually make it flat, swing it back. Once we have put in the screw in the C1 lateral mass and the C2, you can just hold it and swing it back. And as you would be able to see that's the post-op CT. You can see the C1 has been brought over the C2, and you can actually swing it back, and you can achieve a good result, good reduction in all the planes, and a very good outcome actually. But obviously, I would like to tell the viewers something, that this is this requires a lot of experience. You have to focus on the joints and keep on working on it, and then gradually you will be able to do these kind of cases. One should not begin with these kind of cases.
Atish, I think Dr. Jain is back with the voice, so maybe you can.
That's good. That's good. Okay. Here is the scenario 8. Here is another patient with a similar kind of things where the C1 lateral mass is completely fused with the occipital condyle, and the joints are well aligned. And in this patient, once again, Professor Jain, could you just comment on this X-rays, MRI and CT, and give us your thoughts on what exactly you will do for this patient? Professor Jain? Hello?
You have to unmute. You have to unmute, sir.
Can you hear me? No? Okay. This is once again, in this patient, there is an assimilation of the occipital condyle, And there was significant abnormality of the C1 lateral mass. The vertebral artery was abnormal in this patient. Okay, for this patient, we did the same joint distraction technique, but because the C1 lateral mass was completely merged with occipital condyle, we gave a support to the occiput where it will hold it much more better and drags it down. So Praveen, can you just tell us your joint technique, how you do, and what are the technique, the precautions you take, and how to go about it? Praveen, over to you.
Okay. Is my screen visible?
Not yet. Yeah, now it is visible. Please make it full screen.
Gautam, can you please call Dr. Jain and tell him how to unmute? Praveen, if you just directly go to video, that will be much better.
Just I would like to just on 2 points. Actually, what one has to realize is that there is the joint movements, as you had previously said, at C1, C2. We have flexion extension. There is some AP translation, some rotation. That's the maximum movement. And there is lateral bending and lateral translation. So if these are the movements, dislocation can happen in any of these planes. It is not restricted to the so-called anteroposterior and the vertical basilar invagination. It can actually get dislocated in multiple planes, and we have to actually look for what is the kind of dislocation that patient has actually suffered from. So so as we can see here, that's the normal joint and that's the abnormal joint. There are multiple papers we have published it. Professor Chandra has published it. That the joints are normal. So
could you go to the slide presentation? And
actually, it's just not.
Okay, no problem. No problem.
Okay, sure.
All right. So this is
what I will do is I will ask Dr. Neeraj.
Yeah. So as we can see here, so the abnormality of the joint is not only in one plane, it is actually both in the sagittal as well as the coronal plane. So that is an example you can see here, sagittally inclined. This is again coronally inclined. So having said that, all this was published. So if you can drill the joints in both the planes, you can make them near normal. Do a wedge osteotomy, just the way most of the orthopedists would do spine surgeons would do for scoliosis. It's the same principle. Drill off the wedge, make it near normal, and just swing it back into its normal position. So that's the concept. And you can actually manipulate it in any position, any direction you want to, laterally, anterior-posteriorly, multiple directions. That's an example which I had shown previously. And without wasting much time, I'll go on to the video. So this is an illustrative case. We can see here, that's the patient, 25 years old male who presented with progressive spastic quadriparesis. He had assimilated arch of atlas with the C2, C3 fused, and there is some basilar invagination, the so-called basilar invagination, which I label as the central dislocation, as said by Professor Jain actually. And this was the MRI. So we can see here the MRI shows a significant compression at the cervicomedullary junction, and this is the video. So this particular. So we can see that the joints are abnormal, and the concept would be to drill off this in both the planes, not in one plane, but in both the planes, so that we can actually make them near normal. So that's the concept I'm working on. And this is the patient's position, a usual prone position with slight extension. And I usually harvest a rib graft. Many people are comfortable using the iliac crest graft, but that's a personal choice. Through a midline incision, the occiput and the C2 is exposed. We follow the go right up to the C1 arch, and the undersurface of the arch can be drilled. Whether it is assimilated or free, it doesn't make any difference. We can actually see the C2 nerve root, section it. I used to do it previously. Now I've started preserving the C2 nerve root as well. And if there is an anomalous vertebral artery, it can be mobilized at this point. So here we can now appreciate the joint. We can see that the C1 lateral mass is actually lateral. It's dislocated anteriorly as well as laterally over the C2 lateral mass. So it has to be somewhere here. So that's the most important thing. So now once it is exposed, we can just insinuate an osteotomy and turn it around. So it opens up the joint completely. We can assess the dislocation. That's the dislocation. It has dislocated laterally. And as I said, we have to chamfer off this kind of wedges. It's a wedge osteotomy. Basically, we make, and both not only the sagittal but also in the coronal plane. So that's what is going to be demonstrated. I begin with the superomedial portion of the C2 facet. So once that's done, we can actually access the C1 arch very nicely. And then the anterior-inferior portion of the C1 lateral mass is drilled. So that needs to be drilled off so that you can release it completely. That's the most important thing. Once this is done, it is released. However vertical the joints may appear, it is possible to do that. Of course, it requires, I mean, you can learn that with a lot of experience, but you can begin with the simpler cases. That's the point which needs to be drilled finally for the anterior release. The end point is actually the anterior capsule of the joint, which needs to be exposed right from the lateral to the medial aspect. So that is exactly what I'm doing, exposing the anterior capsule. And we have to define the C2 isthmus. You may have a high riding vertebral artery, but it makes no difference. So once the vertebral artery is mobilized, if at all it is required, the most important key step here is to expose the entire anterior capsule. So that will define the release of the C1, C2 joints. So then it is, we drill in pilot holes into the C2 pedicle. If there is a higher riding vertebral, we can just go slightly medial to that directly into the C2 body. And this is in the C1 lateral mass in the facet of the C1. Whether it is assimilated, free, vertical, it makes no difference. You should have a, it can be, a screw can be inserted in the C1 lateral mass. And you can see that the joint is completely mobile once it is released. So whether you do anterior release, posterior release, it makes no difference. The idea is to release the joints completely, and the spacer is not for actually distracting, vertical distraction or correction of the basilar invagination. It is for the amount of bone that has been drilled off needs to be compensated with something. So that is the height of the spacer that is decided. And after the spacers have been put in and the screws have been put in, I loosely fasten the rod and then twist him. So that is what is going to be shown in the next moment. You can see that it can be turned around. So this is for the anterior-posterior correction. The rods have to be loosely fastened, not tightly fastened initially. So you can see that there is some anterior-posterior correction brought about now. And this is the rotational thing which I was talking about. You can just hold it, derotate it. So lateral realignment is possible. Swing the C1 over the C2. For this, it is important that we release the C1, C2 joints completely. Once it is done, you completely fasten the rod. And just before the final tightening, it is important because the spacer is still loose. It is not actually jammed. The jamming comes in the end. Once we have released, we have twisted, we have actually derotated the joint. We have brought it into its own position. The final thing is to slightly compress so that the spacer does not slip. It jams into the joint, which we have a new joint, I would say, a remodeled joint which has been created. And once that is done, just tighten the rods completely, and so we can have the final reduction. And you actually don't need a C-arm or an O-arm or navigation in most of the cases. These are required only for very complex cases. And you can see that this occiput and the C2 spinous process is all aligned. So that's, this is the pre-op scan. You can see the X-ray here. The CT, you can see sagittally inclined joints. It has been drilled flat. The laterally twisted joint, you can see that laterally dislocated joint, it has been swung back. So that was the final X-ray. So that is the end of the video. Most of the cases Professor Rudrappa has actually shown. So I would hand him the platform again. Thank you.
Yeah. Before you hand him, Praveen, there are some questions which have come over from the audience.
Yes, sir.
In the previous case where there was a lateral tilt of the head and a lateral tilt, is there a role for unilateral placement of spacer? Is that something which should be done?
as I said, my concept is the amount of the height of the spacer or the requirement of the spacer depends on the amount of osteotomy that has been done. So if it is not done, if you don't need to, if you can just swing back the C1 over the C2, then it is not required. But if in that particular case, I had to drill a lot of C2, a lot of a part of the C1 before I could swing back the entire C1 over the C2. So that required a spacer. So I have a slide on that. I'll just go to that quickly. Yeah, this one.
The second question from the audience is also that when you are drilling so much of the joint and articular surface of the joint, the spacer then sits on the cancellous bone of the facet. So isn't there a problem with subsidence of the spacer and loss of reduction?
No. Because most of the C1 bone particularly is actually has a thick cortical bone. The facetal surface have a very thick cortical bone as compared to the other bones. So even if that kind of, and I do not drill it completely, it's just the wedges that have been drilled off. So graft subsidence happens, but it is very little. I mean, it is as low as 1 millimeter in long-term follow, not more.
Right. And the third is tips for the positioning of the patient. That is the key in all these craniovertebral junctions. What is your tip? How do you start out with positioning these patients? We showed a picture at the very beginning, I remember. But what are the tips? What should the neck be in? Flexion, extension, neutral position? The neck should be in neutral and the head occipital-cervical junction should be in flexion. What exactly is the right way? If it is a reducible C1, C2, how will you position it? In a non-reducible, which means non-reducible by positioning, what will you do?
For all patients, I actually use traction just prior to the surgery. Whether it's, the so-called irreducible, we usually put it a day prior, the night prior. And for the reducible ones, we actually put the traction just after the patient has been anesthetized. Now that takes care of most of the neck movements that would happen intraoperatively. It realigns the neck, and with the weight itself, there is slight extension that happens. The extension need not be extreme, otherwise it becomes very difficult to open up the joints. So slight extension at the OC1 and the C1, C2 joint, and the neck needs to be opened up properly. That's the most important thing. We should not, in the pursuit of extending the neck, one should not reduce the space of the neck for dissection. That is very important. So it is, I would say, neutral position with slight extension of the head.
So do you use traction with a horseshoe, or do you always use Mayfield tongs and in positioning the patient?
Traction with the horseshoe.
Traction. Let me ask Dr. Satish. Satish, there is a question here from the audience which talks about two things they have asked. One is how do you handle the C2 nerve root? Is it always to be cut? If it is cut, is it a huge problem? Can it be retracted? What are the steps? And number two is, how do you manage the vertebral artery in this case?
Okay. First one, the C2 nerve root I'll answer, but the vertebral artery, I have a PPT. I will show it to you at that time. The C2 nerve root, I cut it only if there is, vertical joints, or there is significant, when I place normally I put the osteotome into the joint and make it vertical. So we distract with the osteotome. And if I don't get enough space of the C1, and if the joint is going much higher where the occiput is coming overriding me, at that time I cut the C2 nerve root. To cut the C2 nerve root, you have to have the good venous control. To have the venous control, as I ever say, that you go from the midline, there is a loose areolar tissue available between the dura as well as the venous plexus. You enter there and cut it along the C2 upper part of the lamina, as well as subperiosteally at C1. So when you cut it from medial towards the ganglion, it comes like a layer. It will not come like a bleeding point. So when you see that, as soon as we remove that venous plexus, you will see the ganglion very much. And I cut the root medial to the ganglion. So under the microscope, I'll cut under the medial to the ganglion. And once you remove the ganglion, believe me, it gives a full panoramic view of the joint. You will also be very comfortable to put any instrument, including the drill, rather than when somebody is holding with the retractor down, pulling the C2 root down. You'll be worried about the bleeding as well as the dura onto the one side and the vertebral artery on another side. The space available without removing the ganglion becomes very, very narrow. So higher the basilar invagination and more vertical is the joint, that is the time I remove. And the second thing, the removal of both the roots, except in the patient who is severely quadriplegic and bedridden. All other patients, I find no problem because they find mild hypostasia in the suboccipital region. If the severely quadriplegic bedridden patient, sometimes they develop the bed sore when you cut both the root because they'll become anesthetic. Otherwise, it has no bigger role at all.
Right. Professor Jain, are you here and can you listen to us? Professor Jain? No, he still can't.
Still can't.
He still can't. So let me go to Dr. Mir Bapat. Mir, the question here from the audience is that it was traditionally believed that basilar invagination is an invagination of the spine into the cranial, through the foramen magnum. But with Dr. Goel, a lot of the literature on this, and he has described it as dislocation, vertical dislocation of C1 on C2. So does it mean that all basilar invaginations can be treated by just distracting the C1, C2 joint and putting a spacer there?
No, I think for the audience, we need to understand that basilar invagination has basically two movements. One is upward migration of the dens. And when that is happening, there is a progressive kyphosis of the C1 over the C2. Now, when we try to reduce it only by joint distraction, what we achieve is directly pulling down the dens out of the foramen magnum. The ways of reducing it in the anterior posterior direction, as Praveen had pointed out, are different. That means you can have the C1 listhesis reduction screws. You can have Sarat's technique of extension and derotation. So you have to have 2 or 3 maneuvers in which you restore the anatomy of the craniovertebral junction. So it is not just a pure vertical migration. It is a pure vertical migration where the C1 is toppling over the C2 at the same time and the odontoid is going into retroversion.
Right. Thank you. Satish, I hand it back to you. The questions of the audience are answered.
Okay. Thank you, Gautam. Thank you, Praveen, for your wonderful presentation. Then I'll move on to the next one. Now, as I mentioned, everybody will have small things, how to do the tips and tricks. And Praveen, can you just tell me, how do you do C1 pilot hole if you're not cutting the C2 root?
Now, as you correctly pointed out, cutting the C2 root provides a panoramic view. But if you're not doing that, it needs to be mobilized right up to where it divides into the ventral and the dorsal rami. And then after that, it can be mobilized down. So the assistant needs to hold it down. And then we define the entire, the C1 lateral mass from the medial to the lateral aspect. We look at the midpoint and about 3 millimeters above the inferior surface of the facet. That's the point where I start making the pilot.
Okay. And do you use the same technique both for the pediatric and adult patients, or these are all only adult patients? As one of the questions came in, because the settling of the implant is very common, and in children it will be much more easier. So I just wanted this to the audience to find out, the pediatric and adult, you have the same principle.
Yeah, the principle remains the same, but the amount of drilling in children needs to be very carefully decided upon. Because if I drill too much, it's quite cartilaginous. So so much of drilling is actually not required. The moment you put in an osteotome, it can just, even the osteotome actually cuts the cartilage a bit. So we don't have that kind of drilling is not required. After that, you can settling, rather than settling, it's actually the slipping of the spacer that happens. There is redislocation. So what one needs to understand is, rather than the settling, it is the final, the jamming of the spacers, and the joint has to be fused very tightly to each other. I mean, the C1, C2 facets have to be tightly fused to each other, very close to the joints. At least that is what I believe in.
Okay.
So,
thank you. So did you have any patients who had a failed implant, and how did you deal with that?
Yeah, I had a couple of them. Initially, when I used to use an occipital pre-curved rod, so because and I didn't use spacers in that particular case. So what happened was the bone graft in the joint resorbed, and there was progressive redislocation. The screws from the occiput actually snapped off. So that is the time when I realized that it is better to switch over to the C1, C2 joint fixation as close to each other, even if we are trying to reduce it. And use of spacers in the more complex case where we have actually drilled it, it's extremely important. So in that particular case, the patient was relatively asymptomatic and it got fused in that partially redislocated case. So I left it. But there were a couple of more cases where the spacers had slipped off and I had to actually go in again, remove it. And there was one case which came back with fused joints, the entire construct fused, but it was in the dislocated position. So in that particular case, I had to go transorally and remove it.
Okay, excellent. Thank you. So the next case is a 24-year-old man presenting once again. Dr. Jain is here. Okay, Dr. Sharath, for you, this is the patient with the X-rays and MRI. Can you comment on this? Dr. Sharath? Not there? Okay, Sandeep, can you comment?
Yeah, so in this particular case, we can clearly see that there's a significant posterior angulation of the odontoid tip along with compression on the spinal cord. There is fusion of C1 ring, so it looks like a syndromic one. Again, the C1, C2 joint inclination is quite vertical. There are vertebral, there is a dysplasia of the pars. There is fusion of C1 to the occiput posteriorly. So this, for me, looks like an extension of congenital dislocation with cord compression.
Okay. Sharath is there?
Yes,
Sharath?
yes.
Professor Jain is also here. Professor Jain, can you hear us now?
So can you hear me, Satish?
I can hear you, Sharath. Go ahead.
So now, this is a very typical case of type 1 pseudo joint, what I described in my last publication. So by type 1, I mean that half of the articulation is by the true and half is by the pseudo joint, which is formed by the foot plate, expanded foot plate of the occiput, along with the proximal superior surface of the pars. So you can see that here the joint is not completely vertical. So as a result, half of the cranial weight is transmitted through the true joint and half of the cranial weight is transmitted through the pseudo joint. And what also you can see now in these cases, obviously I would always like to have a CT angio done. In this case, I can see that the vertebral foramen is very large.
Yeah.
And in this case, I would do a DCR with a joint remodeling technique. Definitely there is a severe instability. As you can see, there is indirect evidence of instability as seen by hyperlordosis of the cervical spine. The C1 arch is fused. So in this case, we will release the joint, drill the surfaces of the joint using a diamond drill so that the surfaces become parallel, and you can keep a spacer which is half into the true joint and half into the pseudo joint. Basically, it's a joint remodeling technique. And in all these cases, I would like to do a DCR with a 3-point fixation, which includes occiput, C2 or C3 and C4. Okay. So C2, I'm not too much, finicky about putting in C2 if the pedicle is very thin or there is an anomalous vertebral artery. And if I have difficulties of putting in C3, I can put C3 and C4. And believe me, I've done close to 300 of these procedures. I'm yet to see, I've had issues with infection, I've had issues, some other complications, but I'm yet to see a single case of occipital screw pull out.
Excellent.
So the fact is, some people feel that occipital screws are not optimally something what I believe in my experience to have happened.
So this is yet another case. This is a case. You can comment on this again and go ahead with your video.
Yes. So I will be showing this case in my video, but what you can see is, again, there is a very severe basilar invagination and very interesting finding. You can see that on one side, there is a complete, are you able to see my marker, Satish?
No.
No, okay. So is there any way I can use a marker?
Now we will come to you. Just comment on this X-rays and MRI.
Okay. So
Yeah.
now in the CT scan, you can see that there is obviously a severe basilar invagination, but the CT scan running through the joints, what you find that on one side, there is a complete vertical joint. And this I call as a type 2 pseudo joint, where the entire weight of the cranium is taken up by the pseudo joint because the true joint is completely vertical. Whereas on the other side, it's a type 1 pseudo joint, where half of the cranial weight is taken through the true joint and half of the cranial weight is taken by the pseudo joint. And now in the last paper which we published in Neurospine, we said that there is always a head tilt towards the more abnormal joint. So in this case, the head would tilt towards the side where the joint is completely vertical.
Okay.
And this kind of decisions, seeing the 3D CT, will help us to decide on which side should the spacer be larger and which side the spacer should be smaller.
Perfectly.
Because in 80% of these cases, you have to put up unequal spacers. And coronal malalignment is something which you have been neglecting for too long. So this is a specific rule which we found, that head tilts towards more abnormal joint. So in this case, it would tilt where the joint is vertical.
Yeah, Professor Jain is here. Professor Jain, can you comment? Can you hear? I don't think so. So in both these cases, Sharath, you can tell the audience that embryologically you can clearly see the occiput with the lateral mass of the C1. It forms a single, because the C1 lateral mass develops from the hypoglossal sclerotome. These
That's
two
true.
Yeah, and the C2 is from the C2 sclerotome. So because it is a congenital anomaly of understanding the anatomy and embryology, whenever the occiput fuses with the lateral mass, it has happened purely because of the hypoglossal sclerotome involvement. And it always creates a vertical joint in this patient. In both these cases, there is a vertical joint which will be asymmetrical. It will never be symmetrical, as Sharath said. And it is asymmetrical and always creates a small, you think that is a rotational component. It's not because of the rotational component. It is because one joint slips more than the other because of the vertical load on the spine. So these things are always technically challenging. And that's why I came from the simple cases from the beginning towards the complex ones to see how the simple surgery from the joint opening, simple C1, C2 fusion to joint opening, and now to the next technique where you have to really distract these head away from the spinous process, which we call a DCR technique, which Sharath will explain in his video. Sharath, over to you.
So thank you, Satish. So let me start sharing my screen. So can you see my video?
Yeah, we can see. Go ahead.
Okay. So can you hear the audio?
Yes, we can.
Okay.
No, there is no audio in that. We are hearing your voice.
You're not hearing the audio from the video?
No. It usually won't come. Don't try it. Last time also same thing happened because it has to be connected. Sometime it won't come in Zoom. You can explain.
1 minute. Let me see if I can connect the audio from my, otherwise if it's.
Sharath, while you are connecting the audio, I would like to welcome Dr. Sanjay Bihari, who has come and joined us, though he has been extremely busy. And a few questions whilst we are waiting, Dr. Bihari. There are a lot of young surgeons here who this telecast. Please unmute yourself so that you can answer. The question to you is, when we talk about a simple, for the young surgeons, a simple atlantoaxial dislocation, what are the steps you will take when this patient comes to you to assess this patient? What are step one? What type of X-rays will you order? What CT, MRI? What will be the steps? And then how will you plan your treatment?
So when a patient comes to me, first is that I'm talking about an adult patient. So apart from assessing the neurological status, which includes whether the patient has quadriparesis, I would also like to assess his respiratory status. And if his single breath count is less than 10 and his breath holding time is less than 10 seconds, then it actually means that this patient is having significant respiratory distress and will probably require prolonged ventilatory support. Then the second important thing is doing flexion and extension plane x-rays. And also another very important thing is the length of the neck. So if it's a very short neck, then it is definitely there are multiple clipper field anomalies, or there is fusion of occipit with C1, and there will be a small condyle, and C1, C2 will be fused. Then plane X-ray flexion and extension. If there is a rotatory component to his neck, then it means that when you're doing plane X-rays, as was seen in the last X-ray, we saw that the mastoid was actually overlapping with the C1 and C2. And when the mastoid overlaps with C1 and C2, plane X-rays don't usually give you a right answer, because in flexion, what happens is that it's three-dimensional. So what appears to be translational movement in three-dimensional, because the angle is also changing, so it appears to be reducing, whereas the atlantoaxial dislocation is not really reducing. Then, so therefore, a CT of the CV junction is very, very important, along with CT angiogram, and also doing coronal images to look at the condyles and the C1, C2 joint, and to see whether the vertebral artery is posterior to the joint, which occurs in three instances. One is if the artery is out of the foramen transversarium of C1, or it occurs if there is an intersegmental artery, or it occurs if it's a low-lying pica. So in all these cases, the artery will be posterior to the C1, C2 joint, whereas joint putting pedicle screws and distraction becomes a little slightly difficult there. The other important thing is to see how much is basilar imagination.
Sanjay, we are running out of time. We are coming at the end for these discussions. Now, Sharath, can you move on to the video?
Yeah. So I'll show my video.
Yeah.
Dr. Sharath, what I would advise you, can you just make it full screen?
1 minute.
On the top, there is a green dot. Just press on that green dot. On the left side. On the left side. Top left, just below the Apple logo.
Yeah, correct.
Just press the full screen. Now try to play the video. Are you using headphones?
No, I've removed the headphones.
Yeah, so I think it should work.
Otherwise, Sajarath, you give the commentary.
Yeah, I can give the commentary.
So just give the commentary, it will be better.
Yeah, so this is a technique which has not, this is the 30-year-old male who is presented with progressive spastic quadriparesis, what Satish has shown. And these are the X-rays, flexion and extension. And as you can see, that C1 arch is fused, and there is a hyperlordosis on extension, which gives you an indirect evidence of the degree of instability. And I use that as a very good marker for knowing what is the degree of instability, and also the severe basilar imagination. Now, this is very important. So over here, you can see a complete vertical joint, whereas over here, you can see a part vertical joint, part pseudo joint and part 2 joint. And the joint, the cranium will always tilt towards the more abnormal joint. And this is a constant finding which we have found. So
click again.
Oh yeah, it's moving. So this is a 3D CTO. Again, it shows the tilt to one side, and we do 3D CT for all the patients in order to exclude any anomalous vertebral artery, and that's mandatory in all these complex cases. And that's the MRI. As you can see, it shows severe compression. MRI surprisingly is not so useful for me, because apart from showing severe compression, doesn't do anything. Now, this is what is a technique of DCR, which I've been talking for several years now. We put a spacer, we reduce it. It not only aligns the basilar imagination, but also the atlantoaxial dislocation by utilizing the spacer as a pivot joint, very similar to the Atlas trying to lift the whole globe. So DCR stands for distraction, which is by the spacer, compression between the occipit OC1 as well as the C2, which leads to extension and finally results in reduction. So it's a whole process which has been described in DCR. Now let us see how we have applied it to this technique. Now, in my experience, I've always preferred to use an occipital screws, especially for complex cases, because of a couple of reasons. Firstly, because it reduces the screw bone interface, and it also is much more easier to put. And believe me, in my 300 cases, I've never seen an occipital screw failing. So these are some of my seminal papers where I've described. I will go across. Now, I will also describe the pseudo joint here, and I will directly come to the case, what we have done here. So in this case, because there was a severe basilar invagination, I had to use spacers which are up to 18 millimeters. These are customized spacers which have been designed by me, and I've done a long segment fusion. It doesn't look so good on X-ray, but on CT scan, it looks completely reduced, which I will show you. And this is a short video. So patient is prone, and here we are now exposing the left joint. Now I prefer to use a variable impedance bipolar because so drilling the C1 arch, freeing the left C2 ganglion, and you can see I've pushed up the C2 ganglion, so I was able to save the C2 ganglion on this side. The joint is now exposed on the left side. I've done the foramen magnum drilling, which is mandatory. So I do that using a high-speed drill. So you can see the orientation, and you can see many times the foramen magnum compression, there is a severe compression. In this case, you can see how severely the foramen magnum was compressed. Now I'm exposing the right side joint. And because I'm using this variable impedance bipolar with adequate irrigation, there's hardly any bleeding. And this I've shown it in several surgical demonstrations. This is a left joint. The joints have to be completely disarticulated. You have to really work on the joints. It's like a joint arthroplasty. You have to work on these joints for almost 45 minutes, half an hour to completely disarticulate it and make it loose. And once that is done, that is when I put the spacer. So now the left spacer is inserted. So in cases of severe basilar invagination, I start with the smaller sized spacers and gradually jack it up so that we can obtain reduction. So in this case, I had to change spacers about 3 times, 3 to I think 4 times. So I started with the smallest size, jacked it up. So it's like jacking up a car using a jack. So on this side, I used a 10 millimeter spacer. So I knew that this won't be sufficient, but I never start putting a big size spacer from step 1. So sometimes I can start with just 6 or 7 millimeter spacers. And in this case, I had to go up to 18 millimeters of spacers. So you can see now the spacers are in C2. Now I prefer to do a 3-point fixation, which includes lateral mass screws within the C2, C3 and C4. And this is running at 2x speed because there is nothing much to be shown fixation. Now here I have devised something called as a universal reducer. So here you can see that this is a unique type of a reducer which has a wire reduction as well as a C2 translator. And it has been developed in collaboration with Medtronics, which is able to perform both the distraction as well as the reduction. And you can see how it is being applied. And in this case, we will be using only wire reduction because there is no forward listhesis of the C2, even though it was a very severe basilar invagination. So we are putting a temporary occipital plate over the occiput. This is a prototype of the universal reducer, you can see. And then here I have fixed 2 plates on the occiput. So you can see one proximal plate and one distal plate. So whenever there is a severe, now the wire is being passed, which is looped around the C2, and it is passed through the holes of the plate, it comes out. And there is a special type of tensioner. This is a braided stainless steel wire, which has got 7 times greater strength than the titanium wire. And that is a crimp which is being attached. And to this, I'm attaching a specially designed tensioner, which is capable of performing the reduction. Now you can see as I'm compressing the wire, you can see movement of the C2 and it is coming closer to the occiput and you can see the reduction happening. Few indirect indications that reduction is happening is that there would be a gush of epidural blood and you will start seeing the dura pulsating, and you know that this decompression of the dura is taking place. Now after reducing it, now all the complex cases I prefer to do an O-arm. So in this case, I did an O-arm and I find as expected that there was no adequate reduction. You can see there's only part reduction, but not a complete reduction, which is expected because in such severe cases, you cannot achieve on the single. So now I remove the spacers, the joints are very loose. I actually repeated the process 2 more times. I'm not showing that. And this is the final spacer, which you can see is an extremely large spacer, which has been designed by me and it's not available on the market as of now. And these spacers are actually meant to reduce such complex anomalies. They have been tested, in situ tested. We have done more than 250 times testing. They hold on very well. And you can see I'm using a periosteal elevator to use it like a railroading technique so that the spacer can be pushed inside. So one side, the left side was the side which was tilted more. So we introduced a 16 millimeter spacer on one side and an 18 millimeter spacer on the other side. And now we repeat the same wire compression which was done the first time. See a complete and an adequate reduction. So these are complex anomalies, and the way to do it is gradually gauge. Now this is the pre-op CT scan. You can compare it with the pre-op CT scan. And now a few words about how to contour the rod. I prefer to do a 3-point fixation. So there is a single primary curve and 2 secondary curves. Now the contoured rod is fixed with a 3-point fixation, adequate bone grafting so that good fusion can take place. And this is how it looks post-op. You can see an excellent reduction and the patient improved. Now this is a very short example to show you the use of a C2 translator. So now look at this male who also had a severe basilar imagination in AED. But what was happening here is that there was a anterior listhesis of C2 over OC1 complex. So here also you find a pseudo joint, but the entire C2 is kind of pushed backwards. There's a complete listhesis of also had, which is very rare. We have reported 3 cases in neurosurgery long time ago. This is an extremely rare condition. So we did a DCR with excision of the dermoid in the same sitting. And there is a very rare embryological explanation on how dermoids can happen in association with CV junction. I think we were the only people. This is what happens in severe cases. So when you reduce it, normally the COG, center of gravity of OC1 and C2, they align perfectly with each other. But when there is a severe atlantoaxial dislocation, then once you do a DCR technique, they do not align with each other. So we would require some kind of a pushing force on the C2 so that there is a complete realignment of the center of gravity of both OC1 and the C2 complex. So based on this challenge, we developed the C2 translator, which is now the part of the universal reducer, which we are developing with Medtronics.
Okay, Sharath.
It's over, Satish. Just another 1 minute. This is a very brief video. I will just run it quickly because, yeah. So this is the C2 translator over here. And I'll very briefly, the video is only for a minute. Yeah. So same thing. We have put spacers. They were put an occipital plate. These are the lateral mass screws. So here we put a clamp on the C2 because in pediatric cases, I prefer a clamp to hold on the wire. And we are passing a wire again through the C2, through the occipital plate. And now we are fitting in the C2 translator, which was not used in the previous case. So you can see the C2 translator sits on the C2 spine. And now the cable compression is done through this hole using a cable tensioner. And this screwdriver, which is moving, is actually pushing the C2 forward. So it is taking care of the C2 retrolisthesis, which happens in severe basilar imagination. And for the first time in the literature, this kind of axis motion have been demonstrated, whereby following distraction, you can do compression, extension, reduction, and also the pushing of C2 forward, which completely reduces. And we developed this special type of spacer screws, which can attach with the spacers through the rod so that they can give complete stability to such complex cases by attaching the spacer. In this case, that is what we did. We attached the spacers using a spacer rod to the rod or cervical occipital, and you can see there is an excellent post-operative reduction using the C2 translator as well as the cable reduction. And we did a same sitting excision of the dermoid. So I showed you two examples of how we have, in one case we used a wire compression, and other cases we used both a wire compression as well as a C2 translator. So I'm done, Satish.
Thank you. Thank you. And
can you stop sharing the screen? Yeah. Satish, while this thing, Dr. Srivastav, do you cut the C2 nerve root pre-ganglionic or post-ganglionic?
No, I don't cut. Unless it is bleeding heavily and I'm not able to visualize, in that case, I do cut.
So if you cut, where will you cut? Will you cut
medial to 8?
Is there any risk of dural leak for CSF leak from there?
It is just proximal to it, it should be cut, because if you go very close to the dura, then there will be CSF leak.
Right. Question to Satish. Satish, in this modern day with all these fancy techniques, is there any role for just a pure foramen magnum posterior fossa decompression in patients with these kind of, especially in adult patients with these kind of anomalies?
I say no, because as I said, most of these joints will move and there will be some movement which will always be happening. And if you do only posterior decompression, initially they will see a clinical improvement for about a year and a half. Progressively, they come with a complete compression, and that will become sometimes actually I've seen a couple of patients where they didn't have any syringomelia, they develop syringomelia later on. So because once upon a time, they used to do a big foramen magnum decompression. Nowadays, most of the surgeons, where they cannot do the complex surgeries, they'll do a minimal less than 5 rupee coin FMD, that is a foramen magnum decompression. And in spite of that small one, the patient developed further kinking and syringomelia. As far as possible, when there is, the Atlantic dislocation or basilar imagination, doing only posterior fossa thing is not at all acceptable in the present day.
Right.
So let us move on to the next case. This is a case, once again, a classical case of Atlantic dislocation. And here we will see how the Sandeep will do the anterior release. Sandeep, go ahead with the video, please.
Yeah. Okay. Thank you. So
because this anterior release, there are two ways of looking at it. Many of us neurosurgeons, now as Sharath and Sanjay and Praveen said, rarely nowadays we go anterior, and unless there is an anterior compression or anteriorly something holding. But considering the DCR technique, sometimes it might find very difficult to many people. Implants may not be there, and the technology is still not developed. Ultimately, what is important in CV junction is mobilizing the joint completely free, like your knee joint, how you do in arthrosis, release it completely from anterior and posterior. Then whatever the maneuver you want to do, it can be done. So anterior releases have the role, and Sandeep will tell how it can be done.
Yeah. So can you see my screen?
Yeah. No, we are seeing you. Please share your screen.
One sec. Yeah.
Yes.
Yeah.
Now we can see your screen. Please go on.
Yeah. So
Sandeep, please go directly to video. Then it'll be easier for us.
Just a couple of things before we actually go on to the video, which are very important. So I just skip through the indications part of it, and we have gone through all sort of cases. Like these are cases. This is a procedure which is basically indicated in fixed atlantofacial dislocation because of post-traumatic or dysplastic conditions. There are relative indications like vascular anomalies of fenestrated or intersegmental vertebral artery, or something which we cannot see, like is intraosseous vertebral arteries, which can actually have a dangerous or a catastrophic effect if we don't realize it. Now, what's the rationale of doing an anterior release? Now, so far we have been talking about AAD, and we have been talking about is the joints. So just a word of caution over here. In atlantoaxial dislocation, whenever there is a forward slippage of C1, there's also significant amount of kyphosis, which causes contracture of the anterior structures, namely the longus colli, the longus capitis, and also the ligaments, which are there on the anterior aspect of the OC1-C2 complex. Now, we all talk about these ligaments, but there are few ligaments which are there posterior to the odontoid, which are called as retroodontoid ligaments, and like the transverse ligament, the alar ligaments, and the apical ligaments. Now, whenever there's a dislocation of C1 over C2, these ligaments are either contracted or stretched, and there are reports of these ligaments undergoing calcification, which can significantly block the reduction. So what's the whole rationale of doing an anterior release? In addition to the decompression, which we usually use as a salvage method, like you have a posterior approach and you find that you haven't decompressed the cord totally, you go in and do an anterior decompression. However, there is a role of anterior release as a primary procedure, because it will definitely release the contracted structures anteriorly. It will cause reduction of the vertical translation. You can distract the joints either anteriorly or whenever you're doing a posterior procedure, and that reduces the basilar invagination. Also, you can use the middle column or the calcified ligaments or the tight structures, retroodontoid ligaments, as a hinge upon which we can compress posteriorly and correct the C1, C2 kyphosis. And both these things can cause a good reduction. Now, going to the anterior approach, what are the zones to work on? So the first thing that I do is that I usually try to look out for the C1 anterior tubercle, which is the most easiest landmark to palpate. Moving distally, I expose the anterior aspect of the C2 body. Now, if you're doing only a release procedure, then probably just an excision of the longest muscles, that is the cola and capitis, is good enough. And you can then move on distally onto the joints. However, if you are doing a plating or an instrumentation, which I have done in a few cases, you need to expose a fair bit of lateral mass, which is around 1.5 centimeters on either side, making sure that you don't go far too laterally, otherwise you might injure the vertebral artery. After you have exposed the anterior aspect of the lateral masses, there's a sequence in which you move down and try to open the joints. After you have worked on the joints, then you try to come medially onto the C2 superior articular process onto the C2 body. Now, there's a sequence for this, because there are zones which you should not venture into, and the inferior border of the C2 lateral mass is very important. Here you can see that's the C1, C2 joint. And if you try to, you're in a hurry to reach the lateral aspect of the C2 body or going onto the C2 superior articular process from the C2 body, you can venture into the vertebral artery, which is approximately 8 to 10 millimeters inferior to the edge of the lateral mass. So that's one area which you should avoid. Also, if you see the C1, C2 joint, the vertebral artery is immediately lateral to the lateral margin of the C1, C2 joint. So this is one area which I never venture into. In fact, you can keep this this particular lateral capsule intact, so that you can use it as a hinge to gradually reduce the joints, and also it protects the vertebral artery. So that is something that you have to avoid. Now, going to the actual technique, I'll be running this video through this particular points. Just a word of caution, this video, in this particular approach, the only person who can see what is actually happening inside is the surgeon himself. There's nobody else who can see what is happening inside. So this particular video was shot with an endoscope. So that's the position. We had a fair discussion about the position of the patient. I am very, very cautious about the position that I give in fixed atlantoaxial dislocations. The position is neutral, or it might be flexion before I do a release. Once I do a release, I might actually lower the head support and ask my colleague or assistant to pull up the chin to cause hyperextension at the C1, C2 joint. Avoid heavy traction, because what happens is that if it's a fixed AAD, then if you give traction, a heavy traction for reduction, the odontoid tip might actually move slight distally, and we have 2 patients who actually lost the signals when we gave heavy traction in these cases. Also avoid hyperextension. So that's a greed that we all have, that patient under general anesthesia, let's try to pull up the chin and see how much it reduces. Now this again, if you have significant congenital anomalies or there's fusion of C1, C2 joints, this is not going to move whatever you do. And if you try to give hyperextension, you might actually push the occipitalized C1 inside, and that can cause compression on the cord. And we have had one patient which also deteriorated like this. So you have to be very, very careful about heavy traction and hyperextension. you need to have your pre-operative landmarks before you operate. So we need to measure we need to see where is the C2 body, the C1 arch, and the occiput. Many a times when the C1 arch is fused, the only landmarks which are available is the occiput and the C2 spinous process, and that gives you a fair idea. A couple of things in the pre-operative planning, I always draw an angle, I always draw a line from the mandible and see where it extends. So if this particular line extends at the level of the C2, C3 disc space, I know that this approach probably might require less struggle. However, in most of the syndromic cases, if you see, these patients have short neck, and this line might actually end up at C4, C5, and that takes a lot of retraction and maneuvering and a lot of patience for this particular approach, because again, you're working too much in the valley. I never expose proximal to the hyoid bone and the posterior belly of the digastric muscle, and this exposure is good enough for you to do all your work as long as you're used to working in the depth of the cavity. So here you can see that there's less angulation, superior angulation, which I need. However, if there is significant deformity and there's short neck, then the angulation that I require is much more. And in these cases, I use a Dever's retractor, which sort of retracts the whole oropharynx anteriorly and not superiorly. So retracting the oropharynx anteriorly is the main issue, is the main trick in this case, and not try to retract it superiorly. Otherwise, you might land up with nerve palsies. So that's the skin incision. I take a long incision extending from the sternum to the angle of the mandible, and sometimes beyond that. The chin has to be kept free so that your assistant is free enough to maneuver the chin, giving hyperextension and giving you an idea about the reducibility. The superficial the dissection is the same as we do in a standard anterior approach for the lower cervical spine. I'm just going to rush through this till I come to the proximal dissection. So I have exposed the longest cola in this case and the prevertebral fascia, and I usually put a roller pack right up to the C1 arch, just slide it below the fascia, which is a safe plane, rather than putting it above the prevertebral fascia. So that's what I am doing in this particular case. Now comes the proximal dissection. So there has been a lot of controversy as to the incidence of hypoglossal nerve palsy and the soft tissue injuries. Now the trick here is that once you reach the odontoid, the hyoid bone and the posterior belly of the digastric, do not try to dissect above it, because I am really not comfortable over there. More often than not, this particular exposure is good enough. There's a lot of soft tissue and vascular tissue which is at the proximal part of the incision, which you probably might have to be a little patient and ligate all those vessels. The superior thyroid artery is ligated, and then I use a Dever's retractor to retract the whole thing anteriorly. So that's in this particular case, the angle was not too vertical. So I use a right angle, but usually I use a Dever's. So that's the C1 arch, which I can feel over here. So I put in a finger, feel the C1 arch, put in a artery over here, and that's the first landmark that I usually try to get to. So that's the C1 arch which has been exposed. So that's the C1 arch. So I put the Dever's retractor on the C1 arch and just tell my assistant to push it down. So don't be in a hurry to ask him to lift it anteriorly, because if that happens, then invariably there will be hyperextension and the patient might land up in deficit because you haven't completed the exposure. Now, once you have done the C1 arch, then there's a sequence to be followed, which I usually do. I go on to the lateral aspect of the C1 lateral mass on either side, the right and the left. There is the attachment of the longest coli muscle on this particular ridge on the anterior aspect of the C1 lateral mass. So what I do is that I use an artery, put it on the tip of the anterior tubercle of the C1 arch over there, and I hitch the longest coli. So it's very important not to cut blindly the longest coli over here, because if you venture too far laterally, you might injure the vertebral artery. Also, in significant amount of cases, there's a rotary subluxation. You really don't know where the C1 lateral mass is. So it makes sense to go in piecemeal and get the cut the muscle. Once you have done that, then you just slide distally onto the C2 body. So that's one area that you need to expose. Many a times in significant kyphosis, the odontoid is deep down inside. There's a lot of vascular tissue in between the C1 and C2. And if you try to venture into that vascular tissue, it's going to bleed quite a lot. So once you expose the C1, then you try to expose the C2 body, and then you go on to the lateral masses of the C1. So that's the lateral mass of C1 over there. And that's the facet joint which I have exposed. The lateral margin of the C1 it should not be touched. The lateral capsule on the C1 margin should not be touched, because that is the one which is protecting the vertebral artery. So again, that's the C2 body. I'll just rush through this particular video. That's the C2 body which I am exposing, the midline raphe which I am cutting, the confluence of the longus muscles, and exposing the bone, and then going in laterally. Once you've done that, follow the C2 superior articular process laterally onto the area of the C2 at the junction of the area of C2 body with the superior articular process. So that is subperiostally, again making sure that you are very flush with the joint. So make sure that you don't go in too far distally over there, otherwise you're going to land up into the vertebral artery. Now, a couple of things which I have realized by trial and error, even if you get a good release of the C1, C2 joint, sometimes you don't get good amount of kyphosis correction. And that is because there's a significant amount of soft tissue in between the C1 and the C2, between the posterior margin of the C1 arch and the anterior aspect of the odontoid. And you have to get these ligaments out. Sometimes there is a calcification. We also have gone through this approach, and without excising the C1 arch, we have managed to get the piece of the odontoid out by piecemeal approach. So that's what I'm doing right now. Again, I apologize for the quality of the video, but here you can see that's the C1 arch which I have undercut after opening the facet joints over there. That's the C1 arch which is undercut, and the C2 which is nicely reduced, flush with the posterior surface of the C1 lateral mass. Then excision of the C1, C2 joints is something which is not very difficult. You just follow the lateral mass of the C1 inferiorly into the C1, C2 joint complex. In cases where there's a significant overhang, you might have to knock off a part of the osteophyte. Usually I do this at the superior edge, at the inferior margin of the C1 lateral mass. Because if you see, the C2 lateral masses are quite thin. It is the height of the C1, C2 lateral masses is almost 10 millimeters on an average, and the height of the C1 lateral mass is 1.5 centimeters, which is good enough. So you knock off the osteophyte onto the C1 lateral mass anteriorly, and then try to go into the joint. So that's the joint which has been exposed on the left side. Here you can see that I'm trying to get the soft tissue out of the joint. Again, a word of caution over here. I use a 90 degrees ball tip probe to feel the posterior aspect of the C1 lateral mass, so that I don't go in too far deep. Otherwise, you're going to plug the venous plexuses that we usually encountered from the posterior side. And that, if starts bleeding through this approach, it takes a lot of time to control these plexuses. Again, as you can see, the lateral margin of the capsule is intact. That's the C1 joint. That's the anterior margin of the joint which I have knocked off. And even putting a suction and sort of angulating it opens up the joint significantly. The same thing is carried onto the right joint on the opposite side. A good amount of reduction is done by excising all the tissue which is between the C1 and C2 facet joint. You can refashion the joints if you want to in this particular at this particular step. And that's the complete soft tissue release anteriorly. And the reduction you have to check by palpating the anterior margin of the C1 lateral mass and the anterior margin of the C2 lateral mass. And once you are sure that these the edges are at equal at the same level, then you probably manage to correct a good amount of kyphosis. So this is one of the case which almost is similar to what Dr. Sarath Chandra showed, that there is a pseudo joint formation, there is a C1, C2 joint dysplasia over there, vertical joints, and I managed to knock off the part of the C1 lateral mass, give distraction, and then go in posteriorly and correct it. In all these cases, then you probably managed to correct a good amount of kyphosis. Hello? Yeah. So
go ahead.
Yeah, so in these cases, I usually prefer a tricortical graft. I have used a cage in one of the cases, but I was really not very sure of the cages. There are reported instances in the literature where the cage has slipped not anteriorly but posteriorly, and they have to go in posteriorly to get the cage out. But here you can see if you insert a good tricortical graft of almost 8 millimeters or so, 8 to 10 millimeters, and you release the traction, you get a good amount of distraction and good compression. And obviously this is through the weight bearing part of the joints, and it fuses quite well. Again, instrumentation is something which I used to do it quite often. Now I have sort of given up because we had a couple of complications where the plates backed out, and this was predominantly related to the design of the plates. So that's the plating on the right side, the left side, and that's the complete reduction, and that's the X-ray. Now, one of the problems that we used to see in these anteriorly plated cases was that we were very sure that the reduction was complete. However, the plate used to give us the impression that there's a little bit of kyphosis remaining. And that is because the C1 lateral mass overhangs the C2 lateral mass by a fair distance. And that was one of the reasons that this gave us the impression. And there has been a lot of study going on lately since the last 4-5 years. Most of the literature comes from the Chinese, where they have worked significantly on the plating techniques and the plate designs in the anterior approach. So this is definitely something which requires further digging in. Similar cases which anterior transarticular screws, just a couple of slides. Similar
Thank
cases,
you, Sandeep. We need to move on, please. Thank you very much for your talk. It was beautiful and very well illustrated. We'll end, but we want to ask you one question. If you can do everything through a posterior approach where you go posteriorly and reduce and fix, why should one think of doing? Is there an absolute indication in your book to do an anterior release?
Yeah, so if you see our cases, you will see that there's the stress on the implant is very less. So if you see, can you just go through that case again, the one which you put over there? Yes, if you see over here, this is purely by an anterior release and posterior instrumentation, the similar case which sir showed, where we could manage to get rid or excise a part of C1. So the stress on implant is extremely less, and you don't have to do any sort of maneuver where you have to reduce on implants. We all know that most of these syndromic patients are either young with poor bone stock or they are osteopenic. And you might have to extend the fusion lower down. Many a times they have got dysplastic C3 posterior elements. So you have to go right into the subaxial spine, which is really not needed in cases like this. So this is one of the method. It might not be the only method, but this is something which is very good to have in your armamentarium.
Thanks, Sandeep. Thank you. To move on, I will show a couple of other cases where the AAD associated with the Basilar Imagination associated with the syrinx. I'm sure all of us will go through the same procedures where you distract the joint and do a good distraction of the occipital cervical region and plate it from occiput to C2. In this patient, the lateral mass, when we are drilling, there is a high riding vertebrae, and we lost the screw in the pars, but we put the laminar one, and we did it. So if somebody was asking how we do a vertebral artery injury, what happens? So you have to presume in all these patients that the vertebral artery is always anomalous. Never take it for granted. And whenever you do that, and nowadays I use the Doppler. This is a simple Doppler available everywhere. If you ask your vascular surgeon, they will have it. I have it in my OT. So whenever I do this, I'll just put it on the ganglion and around the ganglion and around the C1 arch, and you can clearly make out where it is coming. So with this, you will avoid 90% of your vertebral artery injury. So this is, the anterior release is not only lateral approach, even the transverse approach. Once upon a time, we used to do very commonly. This is one such patient where patient has undergone a posterior procedure somewhere else, came with a complete fusion of the posterior mass, but however, a clinical impression, improvement did not happen purely because the atlantaxial dislocation is not reduced. There is still AAD available there, and the joints have not been distracted well. And in such patients, instead of going through the lateral approach or once again the posterior mass, which is fused very well to take it out, you can go through the transverse dendritectomy, which I will not be showing the video this time. When many of you have seen multiple times, transverse dendritectomy still has a greater role, unlike in the lateral approach, where you have a significant retraction of esophagus, trachea, injury to the hypoglossal nerve. the transoral midline approach is a avascular approach. And in fact, it was slightly exposed more laterally. Nowadays, we are even putting the osteotome into the C1, C2 joint from the transoral approach itself. And it's much more safer because no vertebral artery comes in closer to C2 there, and you can distract to mobilize the anterior release of these things so that you can go posteriorly and fuse them again. So this is yet another patient. Is a very complex patient where they have
Dr.
done.
Satish, can I interrupt you here once?
Yeah.
Can you go back to your last case, please? 63-year-old lady.
Yeah.
So in these elderly, this is of course a post-operative case, but suppose this patient came to you primarily without having had a previous surgery done, and she's 63 years old. Would you try to do the whole reduction bit, or is it better to do just a decompression and in situ fixation?
No,
do a transoral decompression with a posterior in situ fusion, or a foramen decompression, magnum decompression with a posterior fusion. Would that be something that you would consider?
No, nowadays, to be frank with you, 99% of my patients, everything I do posteriorly, because we have all of us seen these techniques done many a times. Release the joint. That is the 3 mantra. So releasing the joint, opening the capsule, cutting the ganglion, enter into the joint, cut the end plates properly, put the reamer inside, and make sure that the distractions are given in such a way that wide opening of the joint can be done. If this patient comes now to me, I will do definitely only posterior. I will not do transoral.
Right.
So, this is yet another patient where you can utilize the combination. This patient has come with significant quadriparesis, initial improvement, quadriparesis. The post-op, you can clearly see when the patient has come 6 years after the first procedure, and the MRI cannot be done because they've used these stainless steel implants. A lot of artifacts. In this patient, I did the first removal of the implant. Same time, on the same day, under anesthesia, we did the MRI. We got to know the CT and MRI, what exactly is the anatomy. This is literally, once again, now I did the transoral approach because the posteriorly is significantly fused. And once again, posteriorly, I went in, opened the joint, distracted. As Sharath said, we put in up to C3, C4 level, and distracted the joint in such a way that on the table with the traction, and I could very good, the reduction and realignment of the whole joint. So
how do you make, Dr. Satish, how do you make sure that you don't hyperextend the neck when you're doing an occipitocervical fixation?
So this is a positioning is very, very important in this patient. So whenever I do the occipitocervical fusion, I don't use the traction. I use the Sugita frame. What important is when I position the patient, both the ear should be at the same level, and I sit tangentially at the eyebrow level of the patient. The nose tip has to be perpendicular to the fore. So, if you do it in that way, and the external occipital protuberance should be at the roof level. So external occipital protuberance at the roof level, tip of the nose perpendicular to the floor, both the ears at the same level, you will not fuse it in abnormal position at all in this patient. And from the laterally, if you come and look at tangentially, it should look neutral. Eye should be looking at the floor. So if you do these things as a position, you will not extend their head, and otherwise they'll be looking at the sky rather than the floor, which will worsen their problem further. So I will not go to the details of the transoral procedures. This is a wonderful procedure. You had to, every surgeon who wants to do CV junction should know transoral, because as Sharath said, as Praveen said, whenever there is a calcified amount of lesion which is there anteriorly, as I showed in the first case, you had to go anteriorly, release these things, then you can do posteriorly, so that the reduction becomes easier. Believe me, all these are extradural compression. And maneuver, if you are aggressive in your maneuver, you will give the deficit on the table. And any patient who had mild to moderate spasticity, have a quadriplegia later on the table, and you see it post-operatively, all your 10 hours of surgery goes zero, and you will never sleep for hours together. So ultimately, what you have to achieve is release the joint in such a way that with or without your instrument, it should move. That is the crux of these principles. So, for example, in this patient, I can't do transoral. You can see the two carotid arteries completely kissing each other. This is one of our recent patients where we had to go completely anterior and do it because posterior, no, posteriorly I had to do it because anteriorly I could not do any of the procedure because of the carotid arteries. So I will not go further. This is yet another patient with scoliosis secondary to the multiple abnormality in the cervical region, but the patient main symptom was related to CV junction. And whenever you do this thing, address only the symptom of the complex association and treat the problem patient come with, rather than changing their scoliosis and everything, which will be humongous procedure. Even patient may not like it because they are not bothered about that. They are bothered about their neurological complications. Let us go to the pediatric scenario. This is one such patient I was telling you that prenatally he was detected. Patient was operated somewhere else. This is the fetal Haddington syndrome. The patient had come with significant Atlanta axial dislocation. Somewhere else, patient was operated with the cable alone. Cable are ripped off, and he has come with a significant collapse, and there is significant myelinaria changes. And these patients are very complex to do that. And I want the opinion of the panel, how they will deal with this kind of patients. I will go first with Professor Srivastava. Srivastava, if the patient comes to you, what you will do with this patient?
I think Dr. Srivastava has some internet problems. Maybe we can approach Dr.
Professor Jain is there? Professor Jain?
I would suggest Sanjay Bihari can be asked.
Yeah, Sanjay? He's also left. Sharath, are you there?
Sorry. No, Sanjay is here.
No, I'm yeah. So actually, just 1 second. Yeah, I just come back. Yeah. So now here there are two things. This is not a simple case of a translational atlantoaxial dislocation, because you can also see that there is a little bit of rotatory component to it, and that is the reason why this dislocation is not really reducing. Because in a mid-sagittal image, you can see the lateral mass here. And this means that there is a significant rotatory component to this patient. Now, in this case, in the first instance, what I would like to do is to actually do an occipito-cervical fusion with as much distraction as I can of the joints. I would not like to put the screws into the C1 and C2 joints, because often the facets are very, very narrow in these children and they fracture. So do remove these wires, do an occipito-cervical fusion, and achieve as much distraction as possible. Then in the second stage, in case this is not reduced significantly because of this rotatory component, I would still keep the option of a transoral decompression open, because in these children, this particular procedure of removing it and stabilizing it from posterior aspect really, really helps. I have other, at the end of the discussion, I would also tell you when I would opt for a transoral decompression.
Okay.
Satish, can I make a comment?
Yeah, please go ahead.
So these are actually, I think these are some of the most challenging cases, especially, doing CV junction in young children. I've done a kid who was just 3 months of age. They're extremely challenging because the anomalies are highly complex, and then you do not know how they are going to evolve when the child grows up.
Unfortunately,
now, these
patients come to us.
Yeah. So now in these cases, I will definitely, the screws are out of question. The only thing I can do is do a long segment fixation, and I prefer to use Steelman stainless steel rod with titanium cables. So multiple titanium cables which are available from, braided titanium cables which are available. They can be used to fix both the occiput as well as the cervical area. So that can provide a long segment fixation. And it's very important to take multiple cervical levels, because not 1 or 2 levels are not going to hold. They're going to cut through. So unless you hold at least 5, 6 levels, you're not going to have a good purchase.
Remember, so this patient is quadriplegic. Patient is already quadriplegic from birth.
That's okay. But still, it's our responsibility to provide him a stable spine. And Correct. You can see how unstable the spine is when the child is going into flexion. So it's a very complex anomaly. So needs a long segment fixation with stainless steel rod with multiple titanium braided cables.
So your aim is to provide the stability, but neurologically we can look later.
Yes, absolutely.
Okay. So I will not go. This is another case which we have done. So surgical condition, consideration in pediatric cases are different, because C1 arch, as mentioned by everyone, is cartilaginous. Wiring technique is sometimes futile. Lateral mass fixation should be meticulous. Whenever we do, it should be bicortical. No manipulation, it will tolerate. And if manipulation is done, it should be done at the joint level, not with the implant reduction. And implant consideration is the biggest thing because variable screw sizes are required and pre-op preparation is mandatory in this patient. And remember, most of these children will have a high mobility of joint and they're not at all compliant with the post-operative arthrosis. So extremely careful when we are doing this. So all these patients should be done with intraoperative neuromonitoring, which is the rule in the present day. MEP is mandatory, followed by SSCP. We use every patient MEP and SSCP in these patients, and various methods are utilized, but MEP is the key in this patient. More than MEP, I suggest where there is no intraoperative monitoring, just look at the breathing of the patient preoperatively, as Dr. Sanjay said, single breath count we call. If it is less than 10, he's in severe respiratory compromise. So you had to make sure that they will be induced awake, positioned awake. And when you give the relaxant and everything, make sure you will see the saturation, ETCO2, pulse of these patients, because if any drop of more than 5 to 10 pulse, that means you are manipulating in and around the cord. And if the pulse rate drops more than 8, you have and persists, it is injury to the cord already. So these things are much more important when there is no MEP available to you. If MEP available, well and good. But if not, as a good surgeon, keep your ear on the beep of the monitor along with your anesthetist. So literally speaking, to conclude, whenever there is a symptomatic congenital abnormality of atlantoaxial dislocation, you have to see whether it's reducible or irreducible. If reducible, you can have various methods of fusion available. If irreducible, give attraction to them. And if it's reducing, it will go back to the reducible variety. If it is irreducible, if it is minimally malaligned C1-2 joint opening reduction either with a cable or transarticular can be done. If it's severely malaligned, C1-2 joint should be opened, manipulated. You can do goel fusion. If it's severely malaligned with the C1 toppling over C2, you had to do Dcr technique. And if it's C1 hyperplastic and lateral mass is already hyperplastic where you cannot fix the C1 screw, you have to extend the fusion to OC fusion with a joint distraction. And if it is irreducible, secondary to anterior hindrance between C1 and C2, do the transverse release, do the C1, C2 posterior fusion either by joint distraction or OC fusion in these patients. In case of basilar imagination, if it without AAD, which is rarity, C1, C2 goel technique can be done. With reducible AAD, once again, you can do the same procedure. If it is assimilated C1 lateral mass with basilar imagination, you can do C1 to C2, C0. That means you can put the screw into occipital condyle and C2 to C0, C2 fusion with joint distraction. If BI with irreducible AAD, intraoperative reducible, go back to goel, irreducible DCR technique or reduction technique, or transorally you can release it, or laterally, anteriorly you can release and go back to the posterior fusion again. If patient is coming with ACM with basilar imagination, OC fusion with FMD can be done. If there is a BI with syrinx, goel technique with or without transferal decompression in a severe form can be attempted for these patients. To conclude, these are our learning objective: symptomatic congenital anomalies, BI, AI, along with the OS is the commonest presentation in this patient. Embryology is complex in this patient. Interaction of the occipital and cervical sclerotum is very common in this patient. Anatomical aspect of the compression should be seen. Most scenarios are manageable by posterior procedure alone. Transferal or lateral release is a special scenarios you should use it. And important is release the joint, whichever the means you do, depending on your expertise. And if ortho and neuro work in combination, I'm telling you, a great achievement can be done and you will give a great result to these patients. And in surgical strategies, joint distraction, joint distraction, joint distraction is the mantra in basilar imagination. And both irreducible, whenever irreducible, open reduction and fusion is the common thing. And understand the pathanatomy of both the C1, C2 and occipital region, vertebral artery, and whenever possible for the safe surgery, use intraoperative neuromonitoring. And with this, I conclude my presentation. But if any questions, our panel will be ready to answer for all of you.
Yeah, I actually have a question here. If any of the panelists would like to answer that, and that is that often these patients, because of the compression, so severe compression, will have syringomyelia. What happens to the syringomyelia once you decompress? Does it always resolve? What should we counsel the patients as far as resolution of syringomyelia after the procedure is concerned? Number one. And number two, is there a need to tackle the syringomyelia directly at the same sitting?
Sanjay, can you answer this question to him? Sanjay, are you there? Sharath?
Can I?
Yes, Satish.
Yeah, please answer the the questions which the Gautam asked.
Yeah, so Sarath, you heard that I had asked two questions. One is, what should we counsel the relatives or the patient regarding resolution of syringomyelia after we have decompressed the spine or realigned the spine properly? And number two is there a role for doing a primary syringothecal or syringopleural or syringoperitoneal shunt at these times in hollow cord syringomyelias?
I think very relevant questions, Gautam. So I'll answer the second question first. There is absolutely no role of doing a syringopleural shunt, syringoperitoneal shunt. They never work.
Yep.
So that's the end of that. That's the answer to the second question. Now, the first question is, in my experience, I have seen that when you do an extradural technique, and only thing is when I see a case of syringomyelia, what I do is I drill the rim of the foramen magnum, create a small foramen magnum decompression, and I ensure that I remove the dural bands. Because in all the cases of CV junctions, I found that once you remove the bony compression, there are multiple dural bands. And these are the take a small biopsy forceps, hold it under the microscope and pull it out. So when you pull it out, you kind of tear it, and under microscope, you will ensure that you're not producing a dural leak, and you stretch the dura so that it becomes thin. And sometimes you stretch it so much that it becomes almost translucent or transparent. But I found that this technique of dural expansion without actually causing any CSF leak or doing duroplasty has been very useful in CV junctions associated with syringomyelia. And once I do a very adequate reduction with the DCR, and I do very good dural decompression by cutting all the bands and everything, many cases I find that the syrinx resolves by itself.
Gautam, can you see my screen?
No, right now it is my screen which is being seen. We'll stop my share and you show us your screen.
Yeah, I will show this. Oh, sorry. How to go back? How to go back to the screen?
Try now.
No, it's not coming.
No, I'm sorry. Can you?
Dr. Satish, Just first click. Can you see the button called share screen?
Yeah, I'm doing that. Can you see this, Gautam? This picture?
Yes, we can see.
Yeah. This is the patient, which I wanted to put it because of time constraint I didn't do. A 35-year-old gentleman came with a hollow cord syrinx. Okay, this patient, this was done once again 15 years ago by me. And this is a hollow cord syrinx, okay? This patient I did once upon a time, I used to do a lot of transoral. You see here only with the transoral surgery, and this patient, because I did it as a second case, I wanted to do the posterior approach on the next day because I was too tired. And just for my interest, I did the drilling and did the MRI on the next day morning. And within that time, because of the release itself, and he was on traction still, you can see complete significant resolution of the syrinx alone. So most of these things, whenever you do the good decompression of the cord, and if the clivo-canal line is re-established, unless there is a ACM, and if there is an ACM type 2 is available, I open the dura. Otherwise, ACM type 1, as Sharath said, and if there is an arch of atlas posteriorly fused, I drill off the posterior arch and foramen magnum I extend, and there will be a band, which under microscope, like a hook you take and cut it off, the dura bulges backward. That is mandatory in these patients. And Never do a syringoperitoneal or syringopleural shunt, which has given up, which causes enormous problem to patient at the end of 6 months, not in the beginning. In the beginning, they improve, and which will never be treatable. So because it's the normal CSF, which is an abnormal pathway, you are giving another place for it to go through. We call Abukar's theory, where along the Virchow-Robin space, it enters into the syrinx, that fluid. So you are, by opening the syringostomy or the syringoperitoneal shunt, you're giving another place for it to go in rather than reducing it. So never do those things and reduce the CV junction abnormalities. It will become all right for you.
Right. Thank you very much, Dr. Satish. And I would like to take this opportunity to thank all the panelists. They have done a wonderful job of discussing the entire gamut of CVJ problems. And on behalf of the ASSI, I would like to thank each one of them individually, Dr. Bihari, Dr. VK Jain, Dr. Sarat Chandra, Dr. Salunke, Dr. Mapat, Dr. Srivastav, Dr. Sandeep Sonone, and of course our coordinator. If you have any questions, these are some of the pioneers. You know, as Dr. Satish said, we are very proud in India to have the maximum amount of work on craniovertebral junction. Started with Dr. N.H. Wadia and Dr. Dastur way back in the 1950s and 60s, and then came up with Dr. Atul Goel and Dr. Lahiri in the 1990s. And now, of course, we have Dr. Sanjay Bihari, Dr. Sarat Chandra, Dr. Shashank Kade, and Dr. VK Jain was with us. He has done enormous amount of work on this, and Sandeep Chakravarti has done a lot of work on pediatric C1, C2 and craniovertebral problems. So a lot of work on the craniovertebral junction has come from India, and we are very proud of that. And Satish has already talked about this, so I'm not going to, I just had a brief summary of the problem, but I think it's already been mentioned. So let me just go to this. And that is the ASSI monographs. The ASSI has come up with a set of monographs, which has various topics, but one of the topics is specifically the craniovertebral junction, which was edited by two of our panelists today here, Dr. Rudrappa and Dr. Bihari. It is available to 3ATM and through Amazon. If you want to buy it, it will answer a lot of your questions and make your answers more clear. The entire set of series is available through Amazon and through TM. The books contain topics are lumbar disc herniation, lumbar canal stenosis, tuberculosis, ankylosing spondylitis, early onset scoliosis, craniovertebral junction, complications in spine surgery, and osteoporosis on the spine. So it is available to 3M and through Amazon. Let me also take this opportunity to announce the subsequent coming webinars. The next webinar we have is on Sunday, June the 21st, where we will be dealing with the second part of the first webinar we had on lumbar disc herniation. We will be discussing special situations in lumbar disc herniation. The next master series webinar is on cervical myelopathy, which is on July the 5th. And again, we have a very eminent panel of consultants from all across India who will be talking about this. And the next Pro Series webinar is on June 19th. It will be on lumbar canal stenosis. So please join us for these. And please, if you have any questions or if you have any doubts or queries, please contact me at my mobile number, that is 9820504351, or email me at gautamzaveri1969@gmail.com. If you are interested in becoming a member of ASSI, then you must write to the ASSI Secretariat at issconline.org. Thank you very much. And again, thank you to my panelists and my moderators, please.
Yeah, I personally thank Praveen, Dr. Sharath, and others having participated actively in this. Thank you very much. Thank you, everyone.
Thank you, Satish, for a very wonderful comparing.
Thank you.
And doing an excellent job joining all the lectures.
And most of these cases are my own cases, and the video related is related one to Sharath, one to Sandeep, and one to Praveen. And the rest all things are coming from my institute. And I should thank my team, who is a wonderful team I have, for having participated, and they put in a lot of effort to put these slides into, for this program. Thank you.